And thank you to the ISA for organizing. I think really it's been an excellent symposium so far. I'm honored to follow such great talks and hopefully can build on those. I'm also honored to be here at the Royal Society of Medicine as a physician. I think the last time I was here was 13 years ago when I was still a trainee, so it's always nice to come back. I'm going to talk to you about the latest evidence from low-calorie sweeteners and the role in weight in children and adults. These are my disclosures, so I'm completely conflicted, as you can see, so put on your filters. I've been trained by David Jenkins, so I give intellectual conflicts, financial conflicts, familial conflicts, and anything else that I might think of. So everything's up there, as you can see. We do a lot of guidelines work. I'm a part of clinical practice guidelines where we read the evidence for low-calorie sweeteners, so I put those in red. I think are most relevant, and we have received some research support and some ad hoc consulting and honorary and other fees. And my most important conflict, I always say, is my wife. She works for Unilever Canada, so I share a pillow with industry. So that's my one comedic moment there. We saw some headlines earlier by Stefan. He showed some, and these are just another sampling. And I think we could go day to day with these headlines. But I think what these headlines call out, and I think one of the themes that I'm seeing is really, I think the toxicological questions have really been put aside, and I don't think there's a lot of controversy there anymore. We had a nice set of presentations that show how careful the work and serious the work is in that area. But I think the new concern that's really arisen is the failure to achieve attendant benefits. So they may be safe, but they're not actually doing what they're meant to do, which is to displace excess calories from sugars and actually assist in weight management or with weight loss. And a lot of that, all of those pieces actually track back to this paper. It was a paper in our Canadian Medical Association journal, so I'm sorry for our contribution to that. It's in fact, I think, all the articles they've published, I think it has one of the highest altmetric scores, so it's extremely well cited, certainly in the social media space. That makes the conclusion that low-calorie sweeteners have really failed to achieve the intended benefit, and you can see that there in their main conclusion. So not only in their ability to assist with weight management, but also that there may be associated harm as it relates to cardiometabolic risk. So what are the health authorities saying? I think we had a very nice review of that, and Adam went through some of that with the American Heart. This is just to show you that again. I think, even obviously they've reviewed the evidence even before this, but I think that there is a hesitation to want to endorse low-calorie sweeteners, and whereas you have I think a pretty universal recommendation to reduce sugars, added sugars or free sugars, to less than 5 or 10%, most of the same health authorities are reluctant to recommend low-calorie sweeteners as a strategy to do that. And that's, you can see here, this is the quote from the Dietary Guidelines for Americans Committee. It advises the USDA for the USDA Dietary Guidelines for Americans, and they say that added sugars should be reduced, so there's that, certainly that recommendation, but not replaced with low-calorie sweeteners, but rather with healthy options such as water. So water coming through really as the gold standard preferred replacement, and Adam touched on that in his talk. And then this is the same American Heart Association document that came out, their science advisory, and Adam had very nicely a series of points. I've just sort of taken a series of quotes out of their conclusions, but coming to the same conclusion that they do not recommend them in children. That's the first thing. And the second, that they give a very qualified recommendation in adults, that those that may be habituated to sweetness, they might be useful, but encouragingly, these things are going down, and so we should recommend water, and that water should be encouraged. So with that background, and we've already received a lot of that, what I really wanted to do was struggle through the evidence with you and ask the question, what is the evidence that underpins this? And we've heard, quite a few nice presentations that have looked at that. What I wanted to do is go through carefully and struggle through it with you together, and to do that, I want to invoke an evidence-based framework, the same framework that informs clinical practice guidelines, where we've done a lot of work, or I have personally certainly, and public health policy. And really, this would be a universal system of evidence-based medicine that most would accept in terms of a system where you have, in terms of the units of analysis, decreasing bias as you move up to the highest standard, which is randomized controlled trials. You can see here we've separated systematic reviews and meta-analyses. We've done that, and there's a move to do that, because really the bias relates to the units of analysis. That's the crap in, crap out part that you hear about with meta-analyses. In terms of best practices of systematic reviews, that's quite separate, which is our best way for pooling them. So if we look at the highest level of evidence that informs clinical practice guidelines and public health policy, the starting point really is prospective cohort studies. These are our best designed observational studies. They give us, the why they're important is that unlike a lot of the randomized trial evidence we have, they're able to look at patient-important, public health-important outcomes because of the long longitudinal follow-up and because we don't have large randomized trials of clinical outcomes. They give us, for things like sugar-sweetened beverages or low-calorie sweetened beverages, pretty good correlation coefficients in terms of the assessment of the exposure. They also give good assessments of a number of confounders, some of the known confounders, so one can then adjust for those, long longitudinal follow-up, and then patient-important outcomes like diabetes and cardiovascular disease as outcomes. The highest level evidence, though, comes from randomized controlled trials. If we have them on clinical outcomes, that's the best, but frequently in nutrition, in most cases, they're on intermediate biomarkers. So although they give us a good protection against bias, because they allow for the randomization of confounders between the test and the control group, so you don't have this issue of residual confounding, and you can infer causation where you can't with prospective cohorts, they tend to be on intermediate biomarkers. So if we go through the evidence for those two levels of evidence, starting at the prospective cohort studies, which I would argue is the sort of starting point, and then looking at randomized trials, what does the evidence tell us? So if we look at the prospective cohort studies, there have been a number of, I would say, high-quality systematic reviews and meta-analyses, some conducted by people in this room, like Peter Rogers, who's sitting there, and others that have looked at these questions carefully. But when you look across the evidence from weight through cardiovascular disease, and I'm going to focus on weight. I don't want to steal the thunder of people like Hugo and others and really talk about the others, but there's some similar issues that I want to touch on with those. But when you look across those, what you tend to see is what's so-called inconsistent results that were quoted as part of the AHA Science Advisory, and you tend to see adverse associations equally or even more so than you do protective associations for these outcomes. So let's go through those and see if we can understand why that's the case. So this is a analysis of the Azad paper, that same paper that really was the reason we had many of those headlines about intended benefit, and they concluded that it didn't have the intended benefit, as you can see, for weight, and they actually showed an adverse association with weight. So when comparing highest level of exposure to lowest level of exposure, they saw an increase in weight. Now, an important issue here, and Adam touched on this in his talk, and it's a theme throughout, is this issue of residual causality. So Adam's group did some really nice work on that to show that. And Haynes and some of his data sets, what you can see here is that this is also an issue, and I would say that this is an issue that among serious epidemiologists and guidelines groups is very well acknowledged. So the guidelines themselves acknowledge it, the systematic reviews and meta-analyses that have done the work have acknowledged this, and even the individual prospective cohorts that populate those systematic reviews acknowledge that. They all acknowledge it in their discussion. So it's really not controversial that this data is at very high risk for reverse causality. And what that is, and that was already described to you, is that people that are consuming these may be consuming them actually as a strategy to lose weight. So they're already at risk themselves for gaining weight or having diabetes or cardiovascular disease. So that group is more likely to show an adverse association, not because of the low-calorie sweeteners or sweetened beverages, but because they're at risk to begin with, and that's the reason they're taking them as a strategy. So this is the adverse association you see here. I was at the Nutrition 2018 in Boston, and Peter called out the Azad group on why they used these data, and I think it's an important one. Another issue that came up here was actually the data they selected from the papers. So they preferred baseline or prevalent data of exposure as opposed to change data. And among people that are working in the area of reverse causality, there's really a good consensus that one should be using change data. They've looked at prevalent baseline, change, lag change, and change data gives us probably the best, one of the best protections against reverse causality. And if you look at the same paper, so they cited the Smith paper here, and the same paper was actually a methodological paper that was looking at comparing the prevalent or baseline exposure to change and lag change. What you can see is that those same 3 Harvard cohorts actually showed the reverse when you look at change data as opposed to baseline data. And if you model that, so I took the data out of the paper and I did their transformation. They used t-scores, so I just reran this in RevMan just for this talk. So you can see here actually, depending on the data you choose from the cohorts, you get a different answer. So here, the answer is actually, the suggestion is one of no adverse association. The estimate's actually on the side of protection, although it's not significant, it's imprecise for a benefit. But we're not seeing the adverse association that one sees. And I think that this shows the importance in looking carefully at the prospective cohorts and the methods they've applied in doing that. And this is just to show you Peter's paper. So he actually preferred change data as opposed to baseline data, and you can see he came to a different conclusion. He did not see any adverse association. You can also see that he had other studies. So despite having very similar eligibility criteria, Peter identified more papers than they did, which is another issue. And you can see here in adults and children, you do not see this adverse association. If we look at the case of diabetes, I know this will be covered by Hugo, but I just wanted to make the point that you see a number of these issues. Again, there's this issue of reverse causality that's well acknowledged. The other issue is the one of adjustment for adiposity. So this study was careful in that they went to the authors, they approached the authors of the individual cohort studies to get the adiposity adjusted data. And what you can see is marked attenuation of the summary estimates going from an unadjusted relative risk here for diabetes. This is comparing the highest level of exposure to the lowest level of exposure, increasing 25%. It drops it down to 1.08. So a marked attenuation by adiposity. Again, a way of managing some of this reverse causality. These people are already a bit overweight to begin with and at risk for diabetes. And when you adjust for that, you actually, that association becomes really trivial. It's a very, very small association. The other issue too is that most of these data are based on prevalent data or baseline data. If you just take out, and I just did this for the purpose of this talk, if you just take out the nurses' health study and you look at the change data, what you can see is that these relative risks are attenuated. And in the case of adjustment for adiposity, it really becomes extremely trivial in terms of the association with diabetes. So I think we have to be very careful how we look at the data. And this data also had an issue of publication bias. There were a number of issues that were identified, not just those. But I think we have to we have to be very, very careful with the observational data. And this is just to show you the Azad paper again for these other patient-important outcomes, cardiovascular disease, CHD, and stroke. They showed an adverse association for CVD and for stroke. This issue of reverse causality obviously is important. There's also some indirectness in that there's not many cohorts here available. But the same issue occurs, and I just re-ran some of the data. First of all, this is their data because this data is all change data for CHD, and you don't see any adverse association. I modeled ischemic and hemorrhagic stroke separately, which I think is important. You don't see anything here for ischemic stroke when you're using change data. And when you look here for hemorrhagic, it's really all driven by the women in the Nurses' Health Study 1. And it depends on the model you use. So if you aggregate the data based on a fixed effects model, then you actually see an adverse association. If you model it as random effects, you don't. So this is also the statistical approach you take. So with meta-analyses, we can model it either way. If you model it as random, which gives a little more weight to the smaller studies, a little less weight to the large study, but assumes that there's a distribution of associations and there's not one fixed association, you don't see it. So I think that there is some uncertainty in these estimates and it has to be appreciated. Now, I think a really important question, because it's come up several times, water is the preferred replacement. That's clear from the guidelines. I think for most people, we would say that water probably is the preferred replacement, although preferred replacement is probably what the patient or the person wants to have to replace it. And we don't have a lot of comparisons, but where we do, I think they're really instructive and informative. So there are some of the same prospective cohorts. This is the pool analysis of 3 Harvard cohorts, Nurses Health 1, 2, and health professionals. We've actually got quite a bit of follow-up here. We've got 20 years, we've got here 16 years and 20 years of follow-up. So a lot of follow-up. And what you can see here is when you model as change data, that's the first thing. You see the weight loss, which you would expect, unlike when it's baseline prevalent. And if you compare it to water, it's almost an identical weight loss with good overlap in the confidence intervals. If you then look at other analyses, we don't have a lot of these. These are just the ones that I could find, and I think we need more of these in terms of the analyses of the prospective cohorts. The substitution analyses are doing a lot of this with work as it relates to saturated fat or to sugars or other areas, but they've also done it a bit here with low-calorie sweetened beverages. You can see here, this is a Nurses' Health Study 2. Again, so even when you look at change data, there is a weak association with diabetes. It's not significant in Nurses' Health Study 2. But when you actually do it and ask the question in terms of the intended substitution, how are we asking people to use these and how are they using them? They're using them to displace excess calories from sugar-sweetened beverages. If that's the intended use, what do you see? Well, actually what you see is what you'd expect. You see weight loss in these same cohorts. And if you compare it to water, substituting for a sugar-sweetened beverage, you see a virtually superimposable weight loss. Again, these same prospective cohorts. It's really just the Harvard cohorts that have done this modeling. And this is just to show you another one that was done, and this is for stroke. And so we saw that issue with total stroke. So this was Adam Bernstein's publication. What you can see here is when you model water for low-calorie sweeteners, there is no significant benefit in terms of substituting water for low-calorie sweetened beverages. So I think when you do this more careful approach of looking at the actual substitutions, we don't see a lot of those adverse associations that come out. So I think a lot of the inconsistencies in the prospective cohorts has been really in the way that we've handled the data. And I think if we take more appropriate approaches that manage some of the reverse causality, we can get, I think, a bit of a truer answer. Now, what about randomized, non-randomized controlled trial evidence? What do we see there? So we look first at the question of body weight. This is the Azad paper again, so it's getting a lot of attention. So I'm going to, and driving a lot of the headlines, so I'm putting it in. And what you can see here is their criteria was the studies had to be, or trials had to be 6 months or more. These are the trials that they identified, and they found that it was on the side of benefit, but it was not significant, so not achieving the intended benefit. Now, we wrote a letter to the editor at the Canadian Medical Association Journal suggesting that they'd really failed to appreciate a number of methodological considerations. And I think one of the most important is the nature of the comparator. So again, what is the intended substitution? We want people to use these to displace excess calories from sugar-sweetened beverages. If you're not displacing calories, would you reasonably expect to see a weight difference? I think a priori you would say no. Well, as it turns out, and I don't think they did this deliberately, it's just by setting their eligibility criteria at 6 months, what they captured were these studies. So the comparator was water in 4 of the 7, placebo, because these were some original placebo controls. They're actually taking it in a capsule form, obviously not being used to displace calories. These are probably coming up some safety data, 2 of the 7, or a matched weight loss diet. So out of all of these studies, the comparison was with a comparator where there was not the intended substitution displacing excess calories. So of course you would not reasonably expect a difference. In fact, there was a slight benefit that was not significant, but I don't think one can interpret that to mean then that it's not having the intended benefit, because that's not the way it was used in those studies. And in fact, in the one study that they did take, the Maersk trial, for example, they did have a substitution with sugar-sweetened beverage. It was a diet versus a regular cola, but they actually took the comparison with water. So I think, they by grouping the studies the way they did, they didn't get anything, and you wouldn't expect them to get anything. And this is, again, just showing Peter Rogers' data, showing that when you actually look at the intended substitution in most of these cases, what you're actually seeing in adults and children is what you would reasonably expect. I think if you're displacing excess calories from sugars, then you're going to see weight loss. What about glycemic control, cardiometabolic risk factors? I know Hugo's going to touch on it, but I just wanted to say I think you see what you would expect again. So if you're looking at that intended substitution, you get those attendant benefits in terms of the cardiometabolic risk factors. And I'm going to go through more quickly because I know Hugo will talk about that, but just to show you, we don't see the adverse effects. If anything, you see a protective effect. This is the de Ruyter trial. This is not one of the ones I guess Hugo will go over. This is looking at waist circumference. This is the longest trial we have to date, actually, and it's in children. This is the DRINK trial, 18 months, and you actually see an improvement in waist circumference. This is the Maersk trial again, showing an improvement in liver fat. This is the Maersk trial again, showing an improvement in blood pressure. And this is an earlier paper from the Danish group as well, showing improvements in blood pressure. So you do not only do you see the intended benefit in terms of weight reduction, but you get what you would expect in terms of the benefits that would flow from that weight reduction, which is improvements in visceral adiposity, improvements in blood pressure, and glycemic control. Now, what about body weight? And this is just to show you the analyses as it relates to, and I just wanted to go back, so I skipped over the question. So then the question again here is, well, how does it compare to water, where you wouldn't reasonably expect to see a difference? Do you see any harm above and beyond what you would see with water? And this was done originally by Peter Rogers in that excellent meta-analysis that he did, and you actually saw a significant benefit where the low-calorie sweetened beverages did better than the water. I think you had to be careful in this interpretation. I think he was. It doesn't mean they're necessarily better, but I think he gives us confidence that there's not harm. We've gone and done a network meta-analysis. We've registered and we've presented an abstract form, and we're just in the process of writing up. It's led by a really capable young medical student, Lily Wang. And what a network meta-analysis does is it allows you to go beyond the direct comparisons, where we actually have head-to-head comparisons with water, and leverage indirect comparisons where you have a common comparator. So a common comparator often is sugar-sweetened beverages. Water is used to displace sugar-sweetened beverages. Low-calorie sweetened beverages used to replace sugar-sweetened beverages. You can use that relative effect to determine whether there's a difference, and you can then put the two together in a network. So what you can see here's the pairwise comparisons. We have a couple more since Peter did his, and what you can see is that benefit eroded, but we didn't see any adverse effect, and what you wouldn't expect to see necessarily a difference with water. When you have the network meta-analysis, it's even more on the side of protection but not significant. So when you leverage those indirect comparisons, we've done the same thing for glycemic control and cardiometabolic risk factors. Hugo, not just letting you take away from your presentation, I'm sorry, but we didn't just look at glycemic control, we went through lipids, through to glycemia, and when you compare it versus water, so these are the pairwise comparisons, and here's the network comparisons, and what you can see is there is no difference with water across all of these cardiometabolic risk factors, which again, I think gives us confidence that not only do we not see it as it relates to weight, but even those attendant or downstream cardiometabolic effects that you would expect through weight, they also don't change, which I think gives us confidence that yes, you see it when it's the intended pattern of use, displacing sugar-sweetened beverages, calories from sugar-sweetened beverages, and we don't see that it's any different or behaves differently than water across these outcomes. So what are the conclusions? I think although there are concerns from the cohorts that low-calorie sweeteners may not have the intended benefits, increasing the risk of obesity, diabetes, cardiovascular disease, these associations are at high risk of reverse causality. Again, this is well acknowledged by the authors of all of this work. We're just highlighting it as well. But that they also, I think, where we're trying to make some contribution here, and we want to do a lot of these, reanalyze some of this, is they're attenuated by adjustment for adiposity, measuring exposures as change, and modeling the intended substitution with sugar-sweetened beverages. When you do that, I think you manage that reverse causality, and a lot of those adverse associations go away or certainly are greatly attenuated. Higher quality evidence, again, giving us better protection against bias from RCTs, and we have up to 18 months with the drink trial, show the intended substitution. So again, where it's displacing those excess calories does give you the opposite of what some of those concerns are. You actually see the benefits that you would expect, improvements in body weight and cardiometabolic risk factors. Compared with water, the preferred replacement or gold standard replacement, where here you're looking for harm above and beyond water. You're not seeing it. You actually see very similar in their ability to improve weight, cardiometabolic outcomes, and support the intended benefits. So I think that this data actually offers greater support for when you put it together for their intended use. To address the uncertainties, there's a need for more high-quality RCTs. So, okay, we have to call for more research. My hat's always out. If you want to join us, please. We're trying to design some long-term trials. But I think to address a lot of the uncertainty that's come out of the guidelines, I think we need a better look at the epidemiology, but we need higher quality RCTs. And then I think of the epidemiology, we need to, I think, call on a lot of these cohorts, because we need those data to actually do some modeling to better manage reverse causality, adjusting for adiposity, measuring the exposures change, and modeling the intended substitution. So the Harvard cohorts have done that to a large extent, but I'd like to see other cohorts doing that. I just wanted to say we're running a trial, and I don't really want to get into it because we don't have a lot of time, but where we're trying to answer some of these questions that relate to microbiome and glucose tolerance. It's a trial that's we've just started in Toronto, funded through our Canadian Institutes of Health Research, where we have both water and sugar-sweetened beverages as a comparator. And I just want to acknowledge the sponsors and the people that helped with this. Thank you very much.